Thank you, Professor Kaur, for the introduction. May I request for the slide, please? Good afternoon. I would like to thank the organizer for the invitation and acknowledge the advice of Dr. Patani Vinichagun for this talk. The presentation will cover micronutrients aspect from biological significance to the double burden of malnutrition context, and then the assessment of diets versus biomarkers, and finish with the utilization of data for policy and program. Micronutrients are important for maternal health from peri-conception and for fetal development from early gestation onwards. They are particularly important because the roles and function of this micronutrient at this time is so critical. For example, the implantation, the vascularization, the nutrient transfer of the placenta, as well as morphogenesis, organogenesis, neurological development, and body composition of the fetus. The example of micronutrient that is needed during early gestation is include folate, B6, B12, and zinc. Zinc and vitamin D are particularly important for placental development, while iodine is key for early brain development. So you can see this is a team approach. The nutrition over the life stage is indeed an intergeneration cycle. So nutrition of status of micronutrient during pregnancy lays a foundation for development and performance of the neonates, infants, children that grows into adolescent years or preconception. As you can see, the nutrition-specific implementation across this life stage, nearly half of them involve either single or multiple micronutrients, such as zinc, iron, folate, vitamin A, and vitamin K. Now, these micronutrients work together with energy protein imbalance, as well as other macronutrients, the disease prevention and treatment program, as well as infection control. And they all lead to the outcome of maternal and child mortality, the physical growth, development, cognition, learning, and work capacity that leads to a long-term economic prospects in later years. In the context of double burden of malnutrition, it's known to many of us that undernourished population or poorest of the poor, they have low intake of micronutrients. So when infection hits, this drives the expression of clinical signs of deficiency, as well as impair cognition from children through adulthood. Every year, maternal and child micronutrient deficiency accounts for 500,000 or more deaths of the under 5. And this is an underestimate, which it doesn't include the deaths from neural tube defects, as well as infantile beriberi. On the other end of the spectrum, the overweight and obesity do affect nutrient absorption and utilization. Let's see the evidence on iron next. Among the Swiss children with high BMI, we see lower iron availability for red blood cell production, which is indicated by soluble transferrin receptor. They also show higher hepcidin levels that lead to the reduced iron absorption. despite the fact that these children have normal intake of iron. In Morocco and India, the children with greater BMI show low body iron. When they were given iron fortification, they show a blunted response to the intervention. So we come to the nutrition assessment. So commonly, the diet intake is measured for exposure, while biomarker is determined for status. Of interest, the relationship between these two, the diet and biomarker, are not always straightforward, but the biomarker link more closely to the functional and clinical outcome for effects. Of notice is the intervening factor that would affect somehow the values and interpretation of your results, such as infection, homeostasis, nutrient interaction, and epigenetics. In the dietary assessment, a 1-day or 24-hour record does not account for intravariability in comparison to multiple day recall or record. In order to estimate the population inadequacy intake of a nutrient, it is best to measure against estimate average requirement or EAR, not the RDA. So 1-day intake and the use of RDA cutoff would lead to an overestimation of population inadequacy of nutrient intake. The factor that we have seen in population, like infection, do affect the prevalence. In this case, it's iron. In a population with malaria positive results, this is preschool children, the serum ferritin was elevated highly. So you would think that iron status must be okay. That's not the case. Once you have adjusted for the infection and inflammation marker like CRP and AGP, the prevalence went back up to where it should be. Another example is homeostasis, and this is vitamin A. Thai school children receive fortified rice with vitamin A for 2 months. The response was a significant increase in liver vitamin A stores. However, their serum retinol levels remain unchanged throughout. This brings us to the utilization of nutrition biomarkers to fit different purposes, such as understand the pathway to outcome and impact in research and clinical agenda, or you want to make a choice which intervention works best, or the option of indicator what is available to best evaluate policy or program implementation. For more details, you can visit the publication of the Bond project that use micronutrient as case example. In order to achieve the purpose that has been mentioned, we need data. Last year, the publication that came out to review this show very scarce information on micronutrient status, particularly in preschool children and non-pregnant women. Since 1980, in the low and middle income countries, these are the areas where high prevalence of micronutrient deficiency is expected. So why do we need quality and updated data? Well, first of all, the information will guide us whether the magnitude justify a public health intervention more than case-by-case treatment or not. Also, the data will help identify the subpopulation most affected in order to target interventions. The next reason is that the data could show whether the program's main outcome have been achieved and also track progress against the national or global goals. Besides, we can use that data to explore whether there's a possible risk of toxicity in the situation when excessive consumption has been noted. And the last reason is that data can be used for research, especially to investigate the relationship between status and different health outcomes. Country examples on this matter is very clear in median urinary iodine concentration. These are the values that have prompted multiple countries around the world to launch their iodine salt program and also to adjust the level appropriately for impact and safety. Now in Nepal, adequate urinary iodine concentration has led them to decide to discontinue iodized oil capsule, reduce costs there. The Guatemala, prevalence of vitamin A deficiency motivate research and national vitamin A fortification. And once the impact data show improved vitamin A status, they decided to scale back on the supplementation program, therefore reduce the cost and lower risk of toxicity as well. In USA, where they already have rich flower fortification program to prevent neural tube defects, the data on red blood cell folate helps to identify subgroup for targeted intervention. So these are the examples where availability of data do drive selection and adjustment of programs. In the future, we are going to look into biomarkers from omics method, in particular the metabolomics, which receive high attention as a novel marker for status. Our take-home message for this presentation, first of all, micronutrients do matter as the early foundation from pre-pregnancy to adolescent years. While micronutrient deficiency and undernutrition walk together, emerging evidence show reduced utilization of selected micronutrients such as iron in overweight and obesity. Also, the assessment of micronutrients should be done via purpose, diet for exposure, and biomarkers for status. And last, there's a need for high quality and update micronutrient information, especially from low middle income country for decision making in policy and program. So that's all for now. Thank you very much for your attention.